Good afternoon, and thank you for attending this conference on healthcare after the election, sponsored by the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics here at Harvard Law School. My name is Greg Kerfman. I serve as the Healthcare Policy and Law Editor of the journal JAMA Internal Medicine. On our panel today, we're privileged to have two distinguished experts in health policy, Joe Antos and Chris Jennings. Let me say in advance that Joe and Chris are not here as surrogates for the two presidential campaigns, but rather they're here to bring us two different perspectives on the future of healthcare in the nation. Joe Antos is resident scholar and the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. Joe is one of the most respected experts in the economics of health policy in the nation. He received his PhD and MA degrees in economics from the University of Rochester and his BA degree in mathematics from Cornell. He writes and speaks frequently on the Affordable Care Act, on Medicare, on prescription drugs, among many other topics. I've had the opportunity to hear Joe speak often, and I've come to appreciate his remarkable insight, his wisdom about healthcare economics, always peppered with his own brand of wit and humor. Chris Jennings is an esteemed health policy veteran of the White House, Congress, and the private sector. He currently serves as president of Jennings Policy Strategies, a nationally renowned health policy and advocacy consulting firm in Washington, D.C. JPS Inc. provides policy analysis and strategic guidance to clients on affordable, accessible, and accountable health care. Prior to founding JPS, Chris served as, in the White House as the senior healthcare advisor to President Bill Clinton. He is a popular speaker on all aspects of healthcare policy because, like E.F. Hutton, when Chris Jennings talks, people listen.
Yeah.
Our session will be moderated by Glenn Cohen, professor of law here at Harvard Law School and faculty director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics. Glenn has done a remarkable job building the center. And I should mention that he was the youngest professor on the faculty at Harvard Law School, both when he joined the faculty in 2008 at the age of 29, and when he was tenured as full professor in 2013 at the age of 34. Remember that early voting begins today in Massachusetts, and please join me in welcoming our distinguished panelists and moderator.
No, I put my, yeah, that way we're right.
Just right and left,
right and left,
right?
exactly.
We put them in the middle because we saw what happened in the debate. Having them closer together, right, makes them a little bit nicer, but they're very nice guys.
Oh,
so,
should we shake hands?
I think so. I think it'd be very nice. And thank you, Mr. Kerfman, for the wonderful introduction. Although I do worry it reminds me of the line by Reagan that I won't take my opponent's youth and experience against him, right, with that introduction. So we're going to have a debate is a strong word. We're going to have a conversation with differing viewpoints on a series of issues. And the question really is, we're forward-looking. And I should emphasize in the front end that we're talking really about the parties, not the candidates necessarily. There'll be some of the candidates breaking in, but in particular, I think it's fair to say that we want to know, for example, what happens if the Democrats take the Senate as opposed to if they don't. What happens during the lame duck era of President Obama? So we'll be returning to that. Plan is to go for about 45 minutes with my questions, and then we'll have time for Q&A from the audience for about 15 to 20 minutes. But depending on how things go, we might spice it up and throw some audience Q&A in along the way. When we do take audience Q&A, we'll ask people to line up in front of that microphone, and that's how we'll choose people in the queue at that point. And we'll remind people to keep their comments short. And even though we're talking about political stuff, we're in an institution of higher learning. So I'd encourage you to aim your questions in that kind of mode. Okay. Well, with that said, we're going to have a series of questions to begin with about the Affordable Care Act and its implementation and its future. So I wanted to start by asking you guys a little bit about the exchanges. What is the outlook on the healthcare exchanges? How might the two parties, if they had power, change the exchanges or potentially get rid of them? Anything you can tell us about state-by-state politics would also be very interesting. We'd love to have you guys talk about that for a bit.
Well, first of all, thank you for having us. Do you want me to start, Joe?
Please
or would
do.
You? Okay,
Yeah, go ahead.
Please do. Joe will then correct me on anything that I have to say.
That's because I'm right.
You're right, but you're on the conservative side, but you're wrong on the substance side. So, we will be entertaining, if not informative, today. First, I did want to thank Greg for the introduction, and Glenn, thank you for having us. The exchanges are it's very interesting to note that 6% of Americans are enrolled in the non-group individual market. Okay, 6%, and that's either on or off exchange. And yet it gets about 94% of all media coverage. So it's contextually, people, I think, get the wrong impression of how, and if you look at the exchange relative to healthcare policy in general, it's a dangerous dynamic. Because if you look at Medicare, Medicaid, and employer-sponsored coverage, where the vast majority of Americans are, we've seen very, very low premium growth rates. They have other problems, and it relates to cost sharing and prescription drug costs, which I'm sure we'll get into at some point. But as for the exchanges, we are absolutely in a transition process. It has been a challenge. The danger, of course, is generalizing. Like all healthcare, healthcare is local. You'll know that because in Massachusetts and California and other states, you have some successes. And if you look at those successes, you see particular dynamics. One is that there have been Medicaid expansions. If you have a Medicaid expansion, that tends to make the pool for the exchanges more healthy, and the premiums are lower. Those states also offer plans from those Medicaid expansion states. They tend to have networks that are tighter and costs that are lower, so premiums have been lower. And of course, you have a big issue of urban versus rural. Generally, plans are more comfortable being in urban, large settings as opposed to rural. And so there is this danger, particularly when you're looking at prescriptions and policy interventions to address shortcomings in this area, as to targeting those policies correctly. Nonetheless, it is true that there have been transition issues with the exchanges in general. Higher premiums, those are related, and plan pullouts. Again, you've got to look at the reasons why. If you look at the premiums, you'll start with dynamics, probably three major issues. One is that plans, when they first started probably underbidding their prices. So there were lower bids on the premiums. Secondly, there was selection issues. Selection issues where sicker populations more than healthier populations have come into the marketplace. And thirdly, you've seen some areas do better than others, as I was mentioning before, but where those areas that haven't looked at the more aggressive management of healthcare, you'll find more problems. Those are the three primary problems that contribute to affordability. And that's the last issue, the issue of affordability, particularly for those people between 200 and 400% of poverty. There almost inevitably needs to be more sensitivity, either direct or indirect subsidies, tax credits, or risk mitigation policies. As Joe will tell you, exchanges was initially an idea for the Republican Party. In fact, the exchanges are a necessary element of the very policies they advocate for premium support policy, for moving away from employer-sponsored coverage. And so it's really in their longer-term interest to make exchanges work. However, since we have something called Obamacare, and there's a political dynamic associated with that, we have a lot of hostility, and we haven't had any type of major enhancements of the underlying law, even though it's been 6 years since enactment. As you can tell, I could go on and on and on. I won't. I will just say that there is no one who is a supporter of the Affordable Care Act who has ever suggested that it doesn't need to be improved and enhanced. And indeed, Hillary Clinton has a whole array of policies to do just that. I'm happy to talk about that, but I think I should turn it over to Joe so he can convey whatever he wants to convey.
Well, thanks, Chris. I appreciate you letting me get a word in edgewise.
Certainly.
Greg and Glenn, thanks for your welcome, and thanks to everybody here. Chris, of course, is right. I mean, if exchanges were in the state where the term was invented, although the idea is a pretty old idea, the idea of giving people choices and letting them decide what they want to buy. That's the issue, of course. The problem is not giving people choices. The problem is what are the restrictions on those choices? What are the limitations on health insurers in terms of what they can offer to people? And if you're going to have a guaranteed issue, if you're going to require that insurers take on everyone, regardless of their health condition or any other circumstance that might affect their use of health services, then you have to come up with some way to deal with the inherent risk in that market. And in that regard, I would say that the ACA is highly unsuccessful. The mandate to buy insurance, that's the Democrats' approach to this. We tell you to do it, you should. The problem with that is that the mandate, I don't think, was understood by many people, and certainly the penalty is a very peculiar kind of a penalty. The penalty does not hit anyone until the year after. And you can see why. This is a government program. The government's going to control all of this. And so it's going to take that much time for the government to figure out through the tax system, and maybe longer, did you buy insurance? If you didn't, were you exempted for some reason? There are 14 different reasons, including the catch-all, any other reason that you think would exempt you. And eventually there would be a penalty. It's a relatively modest financial penalty. It grows over time, but it's not a gigantic number. But the key thing is that it doesn't occur at the point that you didn't that you failed to act appropriately. So think of it this way: little Johnny gets a crayon and he scrawls on the wall, and Mom comes and she sees that little Johnny put crayon on the wall, and then a week later turns to little Johnny and says, "Now you shouldn't do that," and gives his hand a little slap. Well, little Johnny is going to wonder, "What are you talking about, Mom?" And that's basically it. Certainly in 2014, anybody who was debating with themselves, should I bother with this or not? In other words, young people. Was there a penalty? Only in theory, but never in fact, because they didn't know anybody who'd been penalized. There was no apparent downside to not buying insurance. Now, I emphasize young people because, of course, young people, especially young guys, have a tendency to believe that they're going to be healthy for the rest of their lives. They discount the possibility of accidents. Of course, who wouldn't? And not only that, but insurance costs money, and there's a bar bill to be paid. Insurance, bar bill. So certainly that first year was a really rough year for the exchanges. It was even rougher than we thought. I actually was surprised at how poorly things went. But that was partly because of the mandate wasn't going to work. that first year anyway. It was just impossible for that to work. But partly because the cumbersome system by which the government was going to control the sale of health insurance really didn't work out. And I would say that it really hasn't loosened up since then, and I think that's part of the problem. But ultimately, rather than trying to say to people, you must do something, it's better to give them a reason to do it voluntarily. For young people, that's going to mean education. For young people, that's going to mean big subsidies, as you say. But the idea that you must buy a particular kind of coverage that is very generous for someone who doesn't think that they need any coverage at all is really a bad sales strategy, if nothing else. Now that said, there are plenty of problems. And the fact is that this is a market. Insurance companies are going to stay in that market if they can make money, and they're going to drop out if they can't. That's the problem. They haven't been able to make money in many of these markets. The insurers that are staying in the markets where they started and are expanding, the ones that are successful are companies that operate in the Medicaid market. Not the kinds of health insurance that you or your parents have. We're talking about companies that are at the low end of coverage, at the low end of pricing, at the low end of compensation. And why is that? Well, it's because when they went to negotiate with hospitals or doctors, hospitals in particular, they're going in and saying, hey, look, there's this new program here, and we can bring in a lot more people to your hospital, and look, we can pay you $10 more per person, as opposed to a United Healthcare, for example, which is at the high end of the market, typically selling coverage through employers. And that kind of a company is going to the same hospital and saying, hey, look, we can bring more customers to you, and we can offer you considerably less than we now pay you through our employer market. You can see there's a fundamental structural defect there that really can't be resolved. So if one had to make a prediction, I think the very reasonable prediction, which we're already seeing, is that the exchange market is kind of a graduate Medicaid program. And I'm not saying there's anything wrong with it. I'm just saying that that's probably where we are. The theory that we were going to have middle-class health insurance for lower-income people, I think, has been largely disproven.
I'll give you a second to back on. I'll give you a second to answer that, but I also want to just invite you guys to share ideas or thoughts on the future of actual Medicaid and actual Medicaid expansion. Will we see the holdout governors slowly kind of come on board, or is this map of Medicaid expansion that we have now likely to be the future map for America?
All right. Well, okay, I'll get to that. But first, that. California blues, Kaiser, all the blues in Florida, et cetera. This is not, it's easy to cast all these dynamics, but again, there's a lot of regional dynamics here. If you look at the California program, they have found very meaningful ways to enhance their program through transparency policies, through benefit design issues, through applying deductibles in ways that younger people find more attractive, et cetera. Those type of interventions can be absolutely applied elsewhere, even independent of some of these subsidy dynamics that we definitely do need to talk about. Just as a reminder, the individual requirement, like the exchanges, came from Bob Dole, Newt Gingrich. Guess what? We're in Massachusetts. Romney Care was an individual requirement. This sort of interesting, divorce of past Republican policy from current dynamics is always interesting. What always happens, of course, is Democrats search any way that you can find a way to make progress in coverage expansion, and so that's what we did in this model. Romney Care is basically Obamacare at a federal level. And if you really want to have a marketplace, you have to have insurance reforms and individual requirements, subsidies, and exchange. Those are the 4 pillars of health reform that you must have. If people want to talk about individual requirements, fine. We can look at alternatives. If Republicans are really absolutely committed to, dedicating resources and subsidies and all the rest, Joe is the thoughtful, rational guy. But remember, the reason why we moved to the Affordable Care Act is that the American public was absolutely frustrated with, and indeed health insurance were absolutely concluded it was unsustainable for the business model of the non-group individual insurance market to be, I do better if I underwrite more aggressively. I do better if I apply pre-existing condition. I do better if I can compete on avoiding sick people. Now we've created a dynamic that we've moved away, and where now insurers have to, at least in theory, have to compete on cost and quality rather than risk selection. And I don't think anyone wants to go back other than people who really don't understand where we were. We were absolutely not in nirvana pre-ACA. It was an unsustainable marketplace. And we need to improve the Affordable Care Act, not regress and have 20 million people lose coverage and have more risk cost shifting and go back to a marketplace that absolutely was unworkable. Now, as to your question of Medicaid, Medicaid is a situation where, again, the hope is that in the aftermath of a new president being elected, and in this case, one with a 2X chromosomes, our hope is that that historic election will not only be historic for that point alone, but because it will represent a shift in 2 things. 1, a new president, a new dynamic. 2, sort of an acceptance that this law will be in place. And 3, sort of an economic undeniability that it is foolish for states to leave so many dollars on the table, which will improve the well-being of their population and make them more competitive as a state for workforce dynamics. Will that happen in every state? Who knows? I suspect within 4 years after her first term, if she gets elected, we'll see, I will call it the majority of those outstanding states coming in. And I'm not going to pick a number after that. But we'll see. We'll see what the dynamics is. And part of the dynamics, I would suggest, will be what happens in the election. And people are going to be looking at both state legislature makeups and the percentage of Latino populations who voted and what kind of impact that had.
And when does the pot sweetener to get them to come in, when does that expire? I'm trying to remember the pot sweetener, what they're giving the states is matching funds. And do you see Clinton administration kind of extending that forward to try to?
Well, if she's elected, she's in her policy. She would enhance that. I don't know if that is an absolute only necessary sweetener, but it would be a sweetener, yes.
Well, I think we ought to actually explain to the audience what you're talking about. So the Medicaid program, the federal government provides matching funds to states for their expenditures. New York, and I suspect Massachusetts, they're high-income states, and so for their normal Medicaid program, they get 50 cents on the dollar. In other words, half of their Medicaid benefit expenses are covered by the federal taxpayer. But other states that have low incomes, it could go up as high as, I think, 75 or 78% or something like that is federal. So with the ACA for the first 3 years, states that expanded to this population up to 138% of poverty, that for those people who are newly eligible under the ACA, as opposed to people who were eligible all along and had never signed up. But for the people who are newly eligible, their federal subsidy would be 100% for the first 3 years, and then it would drift down to 90%. And 90% is still higher than whatever the highest is for the lowest income state. So in that sense, there's always a sweetener. Mrs. Clinton at one point said that, or no, actually Barack Obama at one point said that he would, or was it?
They both.
They both said it. Okay, that any state that came late to the party, that they would like to kind of start the clock at 100% whenever the state came on. That, of course, requires law change, because that's an expenditure of money that hasn't been anticipated by the ACA. But you can see that's sort of the intention there. As far as states moving to expand, I take a more hard-bitten political view than Chris. The hospitals in those states have been pressing since 2010. They're the ones who are going to get the money. And their argument is somewhat correct, which is we're seeing these patients anyway, or these people anyway. They're coming in through the emergency room. And so even though Medicaid doesn't pay us very well, it's better than zero. That part of it's a good argument. Whether it's really true that these people are coming in through the emergency room or not, I think is subject to some debate. But as long as Barack Obama's name isn't on it, I agree with Chris. I think most states, maybe not Texas, but most states probably will take advantage of this. And certainly, if there is 100% funding, it would be really hard to say no, kind of this second time around. One little adjustment, though, on kind of where I stand on things. I'm a conservative. That doesn't make me a Republican. And so
particularly these days.
Well, any day.
Oh, okay.
So when you hear some people say that they want to repeal Obamacare, even thoughtful Republicans who say this, the fact is that when you read their proposals, they're not actually throwing everything out and saying we're going back to the good old days of 2008, which were not the good old days. In fact, there is no Republican proposal that does not include this guaranteed issue that everybody should have the right to be able to buy insurance. There is no Republican proposal that does not extend some kind of a subsidy in some form to people previously didn't get a subsidy. So there are a lot of aspects of the ACA that are now baked into the cake. They're not going to change no matter what. I would say that even if some guy got elected in fall, this fall, I just don't think it could happen, because no matter what he might think, there's still Congress. If you're going to repeal something or you're going to enact something, you have to get through Congress. And in the end, what does Congress stand for? Re-election. So they're not going to dump all over their voters.
I just have to respond to that. If all conservatives were like Joe, were absolutely committed to a thoughtful transition to an alternative policy that somehow worked as an alternative to the Affordable Care Act, I would feel less bad and
not good. Not good, though.
Not good. Less bad. But the reality is that that we've seen what Republicans who are the elected leaders in Congress have done. They have not come up with a policy. They've come up with the policies to cut the programs, to repeal it, to substantially reduce all the subsidies that CBO has projected millions and millions of people uninsured as a consequence. And also, beyond that, they have a Medicaid block grant that in the Paul Ryan proposal is $1 trillion in savings over 10 years, something that Joe would say could never happen,
right?
Which is true, except it's in their budget. And here's the thing. if you are a political elected leader, if you're an elected leader, and you have run for year after year after year on repeal the Obamacare, and the top of the ticket says repeal, get rid of this thing altogether, then the thing that's most natural for them to do is to look at what the Republicans on Capitol Hill have already done through a reconciliation process and pass it. That would devastate the law, would increase coverage, would not provide the protections that you're suggesting, Joe. And I think politically, they would have no choice, because the reality is they used to be able to blame Barack Obama for vetoing it. They no longer have an excuse. They would do it. And I don't believe, at least among the elected leaders, they have a consensus as to what they would want as an alternative other than repeal.
Hold that thought for a second. So this is going to be our last ACA question, then we're going to move on to other topics in health policy. And that is just to talk a little bit about the Republican versus the Democrat vision of delivery system reform, and also cost control, these two together. Maybe they go together, maybe they don't, depending on the vision.
Cost containment has always been a problem. We like to talk about it, but we don't like to do it. And the basic problem, of course, is how do you slow down healthcare spending? By the way, it's never cut costs, because cut costs to most people means that there's less spending next year than there was this year. I don't think we're going to see that anytime soon. Or if we do, a lot of other things will have happened in this country that are pretty unfavorable. So how do we slow down spending? Well, the ACA actually is sort of the textbook on how you do it, or at least how people, elected officials in Washington, have tried to do this over the last 20 or 30 years at least, probably longer, but I'm not that old, or at least I don't remember. Maybe I'm that old and I just can't remember. And which boils down to, you go to the Medicare program, which is where the largest amount of federal dollars is flowing through to get to the health system, and you say, okay, well, we're not exactly sure what we're going to do, but we know how to do one thing, and that is to cut payment rates. So there are all sorts of reductions in the ACA. In order to meet a 10-year budget target, those reductions also grow over time, even though that is politically and practically unlikely, and I think irresponsible. If you get out far enough and you have a big enough cut, you really have a problem. So it probably won't happen. But if you're passing a law in Washington, all you care about from a budget standpoint is, what is my 10-year score? And I'm not going to be around to see the consequences in year 5 or 6, so let's pass it and let the next Congress worry about it. The real challenge is to change the way healthcare is delivered so that there's more efficiency in the system. But in order to do that, you've got to get a lot of things lined up. You have to change the way healthcare is paid for, and I'm going to pick mostly on Medicare, because it is the largest single healthcare program in the country in terms of financing, because its population is clearly they're the biggest users. They're people over 65 by and large, and because Medicare has the rule of law behind it, so that if it makes changes, it's got an awful lot of leverage on the rest of the healthcare system. So you've got to get Medicare. My view is you've got to start with Medicare. If the federal government's going to do anything, start with Medicare and try to change the way it pays for services, and try to have it be more responsible about the services that it covers, and try to have it get patients, get seniors involved. Congress has passed a few bills, not just the ACA, but also, in particular, MACRA, but that's a bill that changes physician payment, that intends to do that. But the problem is, and I'm going to pick on MACRA, this is the physician payment bill that recently passed. The problem with that, first of all, from the congressional side, was they passed a bill that was largely hollow. They basically said, or implied, we don't really know what we want to do. We don't really know what to do. So we're going to let CMS figure it out, and we hope they get it right. Now, that's not terrible. But don't have great expectations that CMS is going to be able to get it right, depending on what you think get it right means. But the big problem is that they didn't fundamentally change the increases in payments to physicians. Over the last 10 years, physician payment in Medicare has increased about 0.5% a year. Over the next 10 years, it'll increase it by about 0.5% a year. There's a shift in the way the money is paid. There are bonuses to physicians who the government has decided are better performers, and those bonuses are largely paid by those physicians who are deemed to be not good performers. But you have a number of problems, because how do you measure performance? Does it have anything to do with patient outcomes? I would argue that largely no, not the way we measure quality these days. But most importantly, finally, the AMA has awakened, and they're against this bill now, finally. They supported it for the first year, but they finally realized, hey, this isn't the deal we hoped we were going to get. And so there's going to be a lot of pressure on Congress. Probably not this next 2 years, but the 2 years after that, I could easily see enough pressure that Congress will push this set of reforms down the road, as it has done with the previous method for physician payment. I think the current system is also going to be pushed down the road. So, can politicians really accept the consequences of major changes in healthcare and healthcare financing? I haven't seen it.
Well, I'm a little bit more optimistic. So, one is it's based on even the conversation around health reform in 2009 and 10, and how hospitals and systems and physicians responded to it, has, at least on the data, contributed to very, very low growth rates. Both, again, in Medicare, Medicaid, and ESI. Kaiser just surveyed the employer-sponsored premiums this year, just going up 3%. Medicare's been GDP per capita, so too has Medicaid for years and years, at levels that we have never seen. In fact, as Joe will recall, at the time of enactment, no one ever thought that we could get anywhere close to GDP +1 or per capita +1.
You can go back further than that.
Well, right, and we're actually still growing at below that level, and as a consequence, over the last several years, the deficit is much lower than CBO had ever projected because of that dynamic. Here's the thing. I agree with Joe to some extent, and I disagree with him in another. One, there isn't much of a cost containment caucus in Washington. That's true. That's been one of my great frustrations, and I think Democrats as well as Republicans should care about that. If you care about sustaining programs in Medicare, Medicaid, you should care about keeping costs low so people can be affordable, can afford their premiums, and that taxpayers will continue to support the programs that we say we care about. And so this whole kind of we're afraid of dealing with this issue is wrong. People should be engaging on that. But I think, and I also agree that the details tend to lead people who generally support the dynamic of delivery reform to suddenly like, oh, I was for that until I'm against it. You know, you can see that on almost every aspect of delivery reform, on transparency. You can go down to almost every issue. The good news, though, is that most policymakers have no real idea what delivery reform means. They tend to be far more engaged in access, and the reason why I'm a little bit optimistic now is for 3 reasons. One is, to Joe's point, Medicare is being far more aggressive on value purchasing. They are switching from fee-for-service to a more of a value purchasing perspective, everywhere from their aggressive implementation of bundling to competitive bidding to ACOs, et cetera, et cetera. And that's making a market signal that is actually quite constructive. Secondly, if you look at this sort of 3.0 version of our health information technology world, where there's real quick information now that is much more useful than it was years ago, and it's actionable. You combine that with some meaningful quality metrics, and this goes to the point Joe was raising, because no one's going to want to move to, like, from the Democratic side, to a capitated payment world without knowing what you're buying, right? You need to know what you're buying and to understand whether it's high quality care. But I think all sides are moving in that direction in a positive way and are not rejecting that notionally, which gives people in Congress, as well as the administration, more sense of optimism about this dynamic going forward.
Great. Well, we're going to shift off the ACA, although it's still ACA related, and talk a little bit about pharma and regulation of pharmaceuticals, drug pricing, these topics, whether there is a split in the parties between what the future should look like, what you guys think the future will look like.
Well, it's a little hard to know where Republicans stand on this. I couldn't say that I know. Certainly, as a political matter, we'll separate politics from health care. This is really, at least right now, a political matter. From a political standpoint, the cry is we have to make prescription drugs affordable. And the problem is, what is affordable? And exactly who is it that's supposed to afford it? So we haven't really sorted all this out, of course. There is the kind of affordability that people are concerned about when they go to the drugstore and they find out what their copayment is. There's the kind of affordability when state Medicaid programs discover that there's a cure for hepatitis C, and since they are, I think they're the principal purchasers, Medicaid is the principal funder for this kind of service, because there are an awful lot of low-income people who have hepatitis C more so than higher-income people, and states also have limited Medicaid budgets, but it also extends to employers as well. So what are we seeing in each of these areas? Well, clearly, not just in the ACA, but also with employer-sponsored coverage, we see more and more multi-tiered formularies, where the most expensive drugs end up in a tier that could be as high as you get to pay the full retail price. In other words, they cover it in a sense. If you buy this very expensive drug and you pay for it yourself, it counts against a deductible, for example, but you still have to pay for it yourself. Or you might pay some high percentage of the negotiated price. Or, depending on the commercial circumstances, it might actually be, even though it's an exotic new drug, it might in fact be highly affordable because of some tied sales between the insurance company and the drug manufacturer. So it's a really complicated question. What does it cost? From the individual purchaser's standpoint, that depends on, do they have drug coverage? That depends on where in their drug coverage this drug may occur. For the insurance company, it's an entirely different matter, because they're buying on a wholesale basis and they're making, as I say, tied sales. For Medicaid, again, a different story. And then for Medicare, we have Part D, where private plans are, in essence, playing the role for drugs that private plans in the employer market play. Would Republicans support some kind of price fixing? There are lots of names for it, but I don't know. There are too many names to suggest. But price fixing is the one that people usually talk about. You could call it negotiation. You could call it lots of things. You could call it value-based pricing, but the value-based pricing is based on somebody's idea about what value is. So in the end, you're just setting a price. Would Republicans support that? Well, maybe with enough adjectives and with enough pressure for selected drugs under certain circumstances, especially a drug that treated, some important person's mother. Yeah, maybe. But in general, giving Medicare the authority to negotiate in general for prescription drug prices, I think that would not be agreed to by Republicans, and therefore, I don't think it, if you need legislation, I don't think it's going to happen, at least for the next few years. I don't think it will work, by the way. Medicare's problem is that it is indeed a public program, and so it's hard for a public program to say no to somebody when it comes to treatments, especially treatments that could save your life. So there are other approaches that also wouldn't work. The other one that's pretty popular among some people on the left is, well, why doesn't the government, in essence, threaten to take over the production of a product? The problem with that is that has been tried in a few cases.
Let me let Chris jump in on this.
But let me just add one thing.
Yep.
Why the sorts of drugs we're really talking about isn't going to work? They're very hard to produce. They're very hard to produce. We're past formulating aspirin. We're now into biologics, which a company that successfully got through the regulatory gauntlet to produce a drug and sell it, they can, if they try to establish a new plant, they may not ever get that authority again. So the idea that the government could do that for the kind of drugs that we're really most concerned about is highly unlikely.
Okay, so first of all, I don't know why for drugs we suddenly say, oh, you can price it at any level you want, and we'll pay it as taxpayers or beneficiaries or whatever. I mean, we don't do that with physicians. We don't do that with hospitals, et cetera. So suddenly, for some unknown reason, because you're called pharma, you can pay as much as you can charge as much as you want, and we will find a way to pay for it. That, I think, is not serving taxpayers well, not serving seniors well. We are seeing some real trend lines here that we have never seen before in the pharmaceutical marketplace. We're seeing launch prices that are extraordinarily high, hundreds of thousands of dollars, not for orphan drugs, not for drugs for very small populations, but for populations of patient populations that are millions and millions. And there's like no sense as to, hey, maybe we should be a little bit more moderate and not just say, oh, let's get as much as the market will bear and screw the taxpayer. So that's one trend that we're seeing. And we're seeing that particularly, as Joe says, in the specialty drug marketplace. Secondly, for brand and generic, that we've seen more and more consolidation. We have fewer and fewer competitors. And where there is too little competition, we're seeing companies inflate their price not once, not twice, not 3 times, 4 times a year, sometimes at 10, 20, 30, 50%. You know, the wage increases in this country are maybe 3%, maybe 4%. The deductibles have increased hundreds of percent, over 200% over the last 10 years. And on top, so they're paying more out of pocket, and the pharmaceutical companies are increasing costs and costs. Now, what else is new that's different? And why am I a little bit more optimistic than Joe? Because we've had these cycles of dynamics. And the industry says maybe we'll moderate ourselves and maybe something will happen. I'm not so sure right now we have an industry that has sufficient competition. And we have incentives from Wall Street for companies to price products very, very high. And I think Republicans and Democrats, if you look at their testimony and their hearings and how they feel right now, are extraordinarily upset and feeling like they have to respond. So if these price increases occur, there will be a demand on Congress and the administration to try to act. And I think that there are certainly ways to do that. And I think it's unacceptable, frankly, to go through campaign after campaign after campaign and say, oh, this is outrageous, but we're not going to do anything about it because the industry is so influential with the Congress in particular. So I'm a little bit more optimistic. I will say the other reason is that stakeholders that haven't been engaged on this issue in years past are businesses, insurers, consumer, labor, yes, but now physicians and hospitals more so than they ever have been, because they're seeing that they have constraints and they're taking on more and more of these drug costs, and they're now coming to Washington saying, you got to do something about drug costs. And now, so you have every stakeholder other. By the way, in Washington, we like you if you're a stakeholder, and if we don't like you, you're a special interest. So just so that's the lexicon in Washington. But for this conversation, we're saying that everyone else is a stakeholder, and pharma is a special interest in this context. But I will say that type of political dynamic is pushing more and more attention and focus on policy interventions.
So I actually want to just get people to start queuing up, because we're going to move to the Q&A. But I actually want to ask you guys, if you have a question, feel free to queue up before the microphone. We didn't talk about a lot of stuff. We didn't talk about public health. We didn't talk about immigration.
Yep.
There's lots more to talk about, and the Q&A could talk about that. But I actually want to ask you guys to play with a few permutations, which is, let's imagine Hillary becomes the president. May not happen, but the polls are suggesting likely. What's the difference in terms of what happens in the Senate and the House for the agendas of each party? How does that kind of make a difference? And then also, what might be possible in the lame duck period in terms of health care?
So so the question is, what happens if there's a split in Congress
versus
versus
one-party rule?
Yeah, right.
In the Senate.
So the most likely split would be Republicans House, Democrats Senate, and the other alternative
is Republicans have both Senate and House.
Seems unlikely to me, but who knows? It's easier to talk about the split. The problem in the Senate is that unless you have 60 votes on your side for any issue, if it's a controversial issue, then it's not going to go anywhere. I think that the era of any party having 60 votes in the Senate is long gone. I don't know that we'll ever see it again, but it's been gone for some time, and it's not coming back. So I think what that means is that for anything that needs legislation, it will really be up to Hillary Clinton to do something that Barack Obama never did, which is to actually go to Congress and negotiate with them in a practical way. And I think she's capable of doing that. There are lots of reasons why I think Obama didn't, and actually I think they're very understandable reasons. But she represents kind of the mainstream Democratic Party, much more than I think he did. And so I think it's going to be easier for her to go and talk to Democrats. And if she's talking to Democrats, I think she's going to talk to Republicans too. The fact is that I think she is potentially a practical politician. And if that's the case, then if there are things you really need to do, you're going to talk to both sides. And when is this going to occur? The answer is maybe an omnibus bill that gets heated up around this time next year and passes on December 24th, the way Congress always, in a very orderly way, passes all good legislation.
I'll try to be very quick. So first of all, I want to pocket what Joe said about Hillary Clinton, that she may be potentially practical. So that's a big achievement today. So I'll go home happy. You know, her history and her record and that of her husband suggests the capability to collaborate. So, and frankly, in a split Congress, you know, that's what you have to do, except to the extent to which you don't require statutory authority. And yes, you know, of course, there will be the tension between what you do via executive action and what you can do legislatively, and you have to, you know, you absolutely have to look at that. I think the split is going to be, it's certainly helpful, but probably more so because it deals with more personnel issue and confirmations, certainly starting with the Supreme Court. And I think, you know, as someone said recently, as you know, personnel is policy, and so you need to get good people. They need to get confirmed. And that dynamic has, implications relative to the day-to-day operations of government. So I'll stop with that.
Great. Let's take some questions from the audience, please. And if you don't mind saying your name and affiliation.
Hi, I'm Christy Hutchison-Jones. I'm with the Petrie-Flom Center. I promise this is not an audience plant situation. So my husband is actually a social worker in addiction counseling in nonprofits around Boston. Right now he's with the Boston Public Health Commission. And one of the things that seems to have been a standard campaign stop, even back in the primaries, was let's go to New Hampshire and say we're going to fix the opiate crisis. One of the things that I don't see people talking much about, though, is that the Affordable Care Act guaranteed access to inpatient addiction treatment, but it doesn't seem to do anything about the kind of addiction treatment. There doesn't seem to be anything in place to talk about whether or not the care is evidence-based or to in any way regulate the care industry. And the thing that seems to be going on right now, as far as I can see in the news, is one where we have state-level regulations going into place to try to limit access to opiate prescriptions. Whether or not that's the best approach, it's what people are doing. And two, increasing access to medication-assisted therapies. But again, not really addressing this question of the quality of care people are being offered in particularly inpatient settings. I wonder if that's just going to remain the status quo and if this issue is going to disappear once the election has passed, or if you think there's any momentum on either side anywhere for continuing to address the addiction issue and maybe getting at the problem of dealing with the quality of care.
Right. Just very, very quickly, one of the benefits of and challenges of running for president is that you go all across the country and you talk to people, and it was incredibly challenging for Hillary Clinton when she was talking to these mothers and fathers of these kids who had died horrible deaths related to opioid abuse. And so that is something that did impact her. But she gets more than most that every health policy issue is more complicated than cut back on source, which of course is what people always tend to focus on. And as you'll see, and as she's done in her policy, she talks about how we need to improve care and access. Now, to your point about, okay, what does that mean in terms of quality outcomes and measuring it, et cetera? I would say this. As you know, we have very poor quality metrics, not just on opioid treatments, right, but mental health and across the board on all health care. And as I said it earlier in the conversation about my greater optimism about delivery reform, is this commitment to and sense of the potential to really focus on not just access to, but what we are accessing and measuring it better. And as over time, holding entities accountable. Otherwise, we're not going to be able to sustain the cost anyway, and nor will we be able to sustain the support for the programs. So I'll stop with that, other than to say it's complicated, as Joe would say, but it's not outside the realm of this issue. The one thing I always say to all these separate groups on opioid and mental health, and welcome accountability, because the purchasers are very suspicious about what works and what doesn't. Purchasers being business, labor, public and private plans.
Right.
And but it should not be siloed. It should be talked about system-wide, so that it isn't like you aren't fully integrated in the broader discussion about delivery reform. Okay.
Joe, do you want to say anything?
Well, so I want to just criticize Washington for a second.
Always a popular attack.
Absolutely. There's a tendency in Congress to pass something and say, "Phew, we took care of that." And I think this is a good example. They're looking for the magic bullet that's political, not the magic bullet for patients. And by the way, for patients, there's not one magic bullet, as you know. There are lots of not magic bullets, but I think politicians have difficulty with anything that's the one big idea, whatever it is.
Hi, I'm Renee Landers, and I'm the faculty director of a similar program at Suffolk Law School in Boston. And I was also Deputy General Counsel of HHS during the first Clinton administration.
Okay, thank you.
My question is that one of the problems with the Affordable Care Act is that it's complexity, it's level of complexity. And you get there because of this attempt to scaffold something new on something that's old that will not bear the weight of the new thing in a clean and holistic kind of way. So the question is, if you were starting from scratch, which I realize is this very hopelessly idealistic question, what would be the goal of structuring a healthcare system that retains the gains we've made under the Affordable Care Act in terms of guaranteed issue and no longer underwriting is selectivity and all of that, and sort of like back at the moment when the UK created the National Health Service or something like that, what would be our goals about structuring a healthcare system that works?
Wow. Well, here's what I'd say about that is that of course, you could not design something more complex than we currently have. And Medicare, Medicaid, DVA, DOD, employer-sponsored, non-individual group, and people going in and out, back and forth, et cetera. So, if we could wave a magic wand, we would want to have, one system. Now, it may not, generally a vision of what we want with regulations that apply. I think in this country, we would tend to still want to have choice, which is to say, people like choice of physician and they like choice of plans. And the reason why they do, I think, is they don't, in America, we trust neither corporations or government. And so we want some balance. Now, I'm not saying in Vermont and Massachusetts and certain other areas around the country they would be completely fine with that. But we are a cowboy-type country, and we aren't a one-size-off approach. But I would say that that's where I would go. It would be one set of rules, one set of systems, one set of subsidies, all these sort of things, but with plans competing to offer that benefit. And I think you've seen that in other countries as well, Germany, et cetera, and I think that would be far more thoughtful. The one thing that, as you all know, the president got in trouble for was this whole notion that you can have mass significant reform without disruption. It's almost sort of an oxymoron. And when he said you can keep what you have, or you can keep your choice or whatever, well, that was mostly true because most people stay in the employer-sponsored market. And of course, by the way, we should note that they love the employer-sponsored market, and they haven't left and dropped into the exchanges as some people thought that they would. But even people, some of them like their underwritten crappy policies, that were cheaper. Some of them, were some of them liked what they changed. But just the notion that you could keep whatever you had in some sort of semi-regulated way, where you're going to have a system where everyone plays by similar rules, it was going to create some disruption. And I think that undermined the credibility of the message and the confidence in it. And that's a separate story, and it's not related to your question, but I hope that's responsive.
Joe, do you want to say anything?
Well, not directly on that question, but related. Our problem in this country is, I think, encapsulated by my own views. I want everything that there is. I want it to be the best there is, and I don't want to pay a cent for it. This is the greatest country in the world. You get all those platitudes, but actually, in the healthcare system, people do tend to act that way. And in particular, if you have a specific disease that you just came down with, the idea that surely all stops will be pulled out to take care of this condition is at least at the back, if not the front, of most people's minds. And the reality is that it is a finite universe. And we're banging into the real limits, not the government limits. We're banging into the resource limits. There's a trade-off between pouring more money into healthcare and putting money into roads. And, you know, frankly, an extra $10,000 for healthcare versus an extra $10,000 to keep that bridge from collapsing, you know, there's some question about where we should be putting the money.
Hi, my name is David Yates. I'm in the Advanced Leadership Initiative as a fellow. My question has to do with California Proposition 61, which would cap the state, what the state can pay for a drug at the level that the VA pays today. So the question is likelihood to pass. Is it going to work operationally? And if it's successful, is it a model that you think will expand to other states?
Yes, no, maybe.
So it's not operational.
Well, yes, maybe, maybe.
But you actually think it's going to pass?
I think it's going to pass.
Huh.
I think it's going to pass. I think I'm not saying it's a thoughtfully constructed policy, and I think the execution of it will be extraordinarily challenging. And I think if it fails to work, which I fear it might, it will undermine the objective, right? But I think we're facing a year where the public is so frustrated with pharmaceutical costs that even though pharma and bio are spending gargantuan sums of dollars in California to kill this, I think the polling number is still pretty high. And we're pretty close to the election. So now, who knows? But this is a change election, you know, and this is why it's a challenge for Hillary to some extent, right? But she has her vision. It's a thoughtful one and practical and all the rest. And I think there's every reason to want to make history with her on the merits. But a third term is always a toughie politically, and that dynamic has that's not just there; it's everywhere. So I think this election night is going to be very interesting. People are going to be looking at referendums. They're going to be looking at state legislatures. They're going to look at governors. They're going to look at members of Congress, Senate, and House. They're going to look at who's voting where, what states are changing. Demographic, dynamics in North Carolina, in Florida, in Arizona, in Colorado, as well as in states like my home state of Ohio, which is mostly staying kind of non-diverse and old and white, which is trending more conservative. So we're seeing shifts all over the place. It's a very interesting thing, and referendums like California are going to get a lot of attention.
You know, it raises an interesting point. Because it's California with a time zone, you know, raises some question about whether people will not feel they need to go to the polls. You know, whether or not the networks announce Hillary, sort of irrelevant. But you know, if you're watching in the afternoon in California and you see that Florida went and a few of the other big states went towards Hillary, you might not go and vote, and presumably it's the Hillary voters who would support that kind of an initiative.
So we're going to take one more question from the audience, and then I'm going to ask you one question. I'm going to tip you off now so you can think about it. You have the president's ear. It's the president of your party, and they say what should be number one on our healthcare agenda. It could be something you talked about, something you haven't talked about yet, but think about that while we get this last question.
Hi, Adrienne Appel with Bloomberg BNA. Hillary Clinton has said that she would like to expand Medicare to people 55 and older. what can you say about, does that have traction, given the potential makeup of Congress?
A couple things. Context first. She did that in response to a question from an older, I think it was a woman in an audience, who said, and I think she sounded like someone who was like at 405% of poverty, who had she had tried to buy the policy in an exchange. She wasn't getting subsidies because there's a cliff right at 4% of poverty. And remarkably, Hillary Clinton on the spot and you may note that this was not a planned rollout. This was her thinking about this policy. But the first response was, we need to eliminate the cliff and extend this 8.5%, which wouldn't cost a lot of money, but you wouldn't have this marginal tax cliff, which would make it affordable. And interestingly enough, well, first of all, the idea that any human being would know the answer to that question or contextually be able to respond to that on the spot is amazing to me for a person, any person. I can't imagine almost anyone in Congress who could come up with that. But secondly, she said, and this was reminiscent of 1999 and 2000, when the administration back then had proposed a Medicare buy-in at a time when we didn't have any exchanges whatsoever. And we didn't directly subsidize it. We indirectly subsidized it as a proposal. And interestingly, it was the only health policy that I ever remember that Senator Moynihan really liked, and he insisted on being a sponsor. But what she was thinking in the response to the Medicare buy-in was that we do have some people who are older, who have a little bit higher incomes, who are having trouble affording their policy even with the age rating, and that maybe we should look at a Medicare buy-in type model. I think the concept being that it could help with the exchange pool itself. In other words, if you pulled out older, sicker population, the exchange pool would be less expensive, lower premiums for everyone else in it, and we could make a step towards a Medicare buy-in. To be clear, the policy is not to lower the Medicare eligibility age. It is to, in essence, be able to buy in with and into the Medicare program. It's to use the exchange subsidies that are available to buy into the Medicare program. All the details of the policy have yet to be worked out. It's something that we're looking at. I think I'll defer to Joe as to whether or not he thinks that the policy is workable with the Republican Party. But it is a sympathetic population, and it's a policy certainly worthy of serious consideration.
Yeah, this is a population also that tends to be voters. So this creates a huge political problem for anybody who isn't so sure about it. If you call it a Medicare buy-in, it somehow sounds nice, but all it is more subsidies. It's just more subsidies. So since the ACA was supposed to provide affordable health care, you could also just do it through the ACA. You could just give them more subsidies. And in essence, I think, getting rid of that cliff is what we're talking about here. It seems impractical to me for lots of reasons for whatever it is, if it were actually to pass, for people to actually go into the Medicare program. I think it would be a separate sort of a thing. The generosity of the Medicare program is quite large, and the idea, for example, we're going to have a problem here with the Part B premiums. Extending this kind of a protection so that your premium doesn't go up only as far as your Social Security payment went up, leaving potentially millions of people paying a lot more because we protected some people who happen to be the right age, it isn't going to work. And of course, the people we're talking about, by definition, fall into they would have to pay more. So there are lots of ways that you could get this wrong. Be actually much cleaner just to extend the subsidy in the ACA. Would Republicans go along with it? It's possibly. The question is, what do you get for going along with it? And I don't think it's necessarily health care. It may be other things. So we'll have to see about that.
Okay, so the last question. You have the president's ear. What's the top of the agenda when it comes to health policy?
Am I talking to Donald Trump? Or?
You're talking to the president you would like to see in office, but just to save us from having to go on the record, you're talking to the Democrat, you're talking to the Republican.
Oh, well, can you start? It might be more entertaining.
Well, as Al Haig once said, I am the president, or something like that. I don't think I can address a Republican necessarily, but maybe. I'm sort of a Paul Ryan without the Donald Trump baggage, maybe think of it that way. And the question was, what's the most important thing, or just kind of what's on the agenda?
What do you say number one on the agenda? First thing you have to do is this.
Well, it's not, quote, repeal Obamacare. That's what it's not. Although there are things that you would take out of what is now in the law that would be part of a repeal and replace kind of a bill. I think that the single most important issue is to look again at this question we talked about earlier about finding a way to slow down cost growth. And since the government is really at the heart of the problem, then the government has to worry about its solution. Now, I have to say that getting out of the way, to some extent, of the private sector wouldn't be a bad idea. Certainly, the big insurers that service the employer market are seeing a lot of pushback for rising costs and so on. So I think there's a lot to be said for a little humility in Washington and realizing that the big insurers and the big health plans that service that middle-class market have as much at stake in slowing costs as the government does, and may in fact find more palatable ways, because if you can't sell it to the middle class, then forget it. It won't happen.
Well, I think I would say you need to focus on the issue of affordability and accountability. And I would say do not make this all about ACA. It is a very relatively small population of the public. The public is engaged at much broader issues, everything from out-of-pocket cost increases to prescription drug costs to better and more accountable health care, from Alzheimer's all the way through Zika. And so I would focus on an array of policies that I think could bring a number of Republicans together. I think the biggest problem we do in healthcare is when we tend to silo this issue apart from every other health policy that is embedded not just in healthcare, but is embedded in our budgets, in our economies, in our tax policy, et cetera. So it would be to focus on that issue and think of thoughtful policies. And then I would, as part of that, say, focus on that theme, because that's where the public is. You can bring everyone to that conversation, and you can throw in all sorts of issues and initiatives within that broader filter.
Great. Well, please join me in thanking these two gentlemen. And if you haven't had enough healthcare policy, we have another event on Thursday in the lunch slot on concurrent surgeries. So doctors who double book surgeries and legal and ethical issues raised by that. And we'll see you on Thursday.
Thank you.
Wow, that's very good.
Good job. Good job.
Very good indeed. Thank you.